Welcome back. Let's learn this pathway that air has to take. So in order to do that, first let's review a little bit of the anatomy of the nose. Up here at the top of the bridge of your nose, you have nasal bones. And then we have a bunch of soft tissue on the outside. Air is going to enter through your nostrils or your nares into the nasal cavity. And the nasal cavity is divided into right sides and left sides by your nasal septum, which anteriorly is made out of hyaline cartilage. And then posteriorly, coming from above, you have the perpendicular plate of the ethmoid bone, and coming up from below, you have the vomer. On the lateral sides of this nasal cavity, you have your three nasal concha or turbinates. And all of this is covered with the pseudostratified ciliated columnar epithelium that you have in a respiratory epithelium. Now, your nasal cavity, as you probably have learned in your life, has a very rich blood supply, so that if you get punched in the face or accidentally hit your face or accidentally poke your nose inside with your finger, you're going to have a fairly robust nosebleed. And what this rich blood supply is important for is to warm the air, to precondition it before it goes any further into your body. So the air also will travel through the four paranasal sinuses, and as well in the nasal cavity right up here, we have the opening to the eustachian tube, which explains how germs can crawl up and get into the middle ear, because this is the only opening into that air-filled middle ear. Looking at the back of your throat or your pharynx, it's divided into three regions. If we follow along from the hard palate to the soft palate, then go across from there, everything above that, which is the posterior aspect of the nasal cavity, that's the nasal pharynx, and that's where the opening of the eustachian tube is, as well as what we call the pharyngeal tonsil up there. Continuing inferiorly, if we find where the epiglottis is coming up from above, then that middle area is the oropharynx, and it also contains two tonsils. Contains the one everybody knows about. Those are the palatine tonsils. And then in the back, posterior part of your tongue, it contains the lingual tonsils. The part of your throat, which is lower than this level, leads down towards the larynx. So this is called the laryngopharynx. So both the nasopharynx and the oropharynx contain your three sets of tonsils. Now, the oropharynx and the laryngopharynx not only are going to bring air that you have inhaled through your nose down towards your larynx, but food which you ingest goes through the oropharynx and laryngopharynx before it goes into the esophagus. Because food travels here, we have to change to a more robust epithelium that can tolerate the roughness of the edges of food. So the oropharynx and the laryngopharynx don't have a respiratory epithelium. Instead, they have the typical mucosa that you expect in the proximal part of the digestive system, i.e. a non-keratinized stratified squamous epithelium. I also want to point out that a little bit of gymnastics has to occur at the level of the laryngopharynx, in that the air which gets inhaled and is traveling posterior to the food that you ingest, they're like this, they actually cross pathways. Okay, so you usually aren't inhaling and swallowing at the same time because it's physiologically impossible. But I want you to realize that the air has to travel from being posterior to go anterior in order to go down the larynx, whereas the food has to make sure it goes down the posterior opening into the esophagus. So let's look closer at the larynx, which is between your windpipe, your trachea, and your pharynx. And it is made up of 9 different cartilages and some ligaments. And so you're not learning all 9 of the cartilages, The most superior one is the epiglottis, which is the one that flips over to cover the opening of the larynx. If you swallow, every single time you swallow, it's doing this. So it's doing this hundreds of times a day. So this piece of cartilage is the third and final piece of cartilage in your body that is elastic cartilage, with your two pinna being the other two locations. So looking at these cartilages anteriorly, we have your thyroid cartilage, which is then connected to the narrow portion of your cricoid cartilage through the cricothyroid ligament. And this is important at times of breathing emergencies, in that this is a midline structure that doesn't have any blood vessels around it. So if somebody is having respiratory strife or difficulty breathing, I'm sure you've seen all the movies where somebody takes a knife and jabs somebody in the throat, and then takes their pencil or their pen and takes it apart, so you have the tube, and then they can shove the tube in that hole. Okay, that's real. That happens hundreds of times every day in emergency rooms across the United States. Okay, we don't use steak knives and pens. We have a big needle set that we do that with. That's not a tracheostomy, because we're not in the trachea, we're up here in the larynx. And we only do it when we can't intubate, put a breathing tube through the mouth or the nose to go down into the larynx. But it can buy you some time. Now, you're not going to be doing anything much with that. If you don't believe me, try to breathe in and out through a coffee stirrer or through a straw and see how much you enjoy that. But it's enough to keep you alive. On the posterior aspect, we realized that the thyroid cartilage did not have any representation, and that the big cartilage is cricothyroid. And above that, we had three cartilages. The largest one, which was the only one that we learned, was the arytenoid cartilage. And it was important, and I will show you why later. The thyroid cartilage has many androgen receptors on it, and this totally explains why after puberty, men's thyroid cartilages enlarge and become an Adam's apple, whereas on women it doesn't occur. And this level where we're going to have the vocal folds in the middle of the larynx, this is our transition from the anatomical upper respiratory tract to everything below, hopefully staying sterile, in the lower respiratory tract. And it's also the site where we are going to be giving up that shared epithelium with the digestive system and going back to our respiratory epithelium. So let's talk about those vocal cords for a second. So you may have had a class where you learned about true and false vocal cords, and we're not going to stay with that mnemonics or those arbitrary words, and we're going to use the real words for these structures. When we look in this area, which is where this pointed area is on the lower right quadrant, if we blow it up, it gives us this picture in the upper left. And what you can see is there is an upper fold, and then there is a lower fold. Okay, so this upper fold is called the vestibular fold, and its job is just basically to protect the lower fold. Okay, so if something, say a wayward peanut or something, or would come down, hopefully it would hit the vestibular fold, and then you would cough it out. And no damage would go to the vocal fold, and then you also wouldn't have it going down in your lungs, blocking a major area, which was always bad news and requires a hospital visit. The lower fold is called the vocal fold, and it's in the vocal fold, which is this mucosa-lined structure, that we have the vocal cords. So you're not really seeing the vocal cords, they are inside, although we do call them vocal cords. They're vocal folds. Anteriorly, these folds are attached to the thyroid cartilage, and posteriorly, and I noticed on a lot of the pictures that I copied from other sites, these are posted with posterior upside down, so I kind of flipped them for you. You can always orient yourself in that the vocal folds are attached to each other anteriorly, and you can tell that also because this and this, these are those bumps where you have the retinal cartilage and the two little cartilages up above it. Okay? And also this big curved structure up here, that's your epiglottis, which is anteriorly. So these vocal folds anteriorly are attached to your thyroid cartilage and posteriorly are attached to your retinoid cartilage. And that's why we learned the retinoid cartilage. Besides, it's a really fun word to spell. And maybe if you're playing Scrabble, it gives you a chance to use that Y in a really long word because the rest of the letters are pretty common. Now the opening between the folds is called the glottis, and that's why that big elastic cartilage is called the epiglottis because it's above the glottis, okay? And at times where you're where you're talking, sorry, and swallowing, this opening, which you see in this particular picture, will close. And I've got plenty of pictures of that, like for instance, right here on the left where they are closed, which increases the tension. And as we all know, is when the air rushes past the tense vocal folds, that sound is produced because these vocal folds have some vibration. And so as you age, as you grow from childhood to adulthood, all of these structures grow in length. And as these vocal folds lengthen, that's where your voice changes from the high-pitched childlike or baby voice into the more mature lower voice. Now, of course, this does not happen overnight. And those boys with those massive surges of androgens enlarging their thyroid cartilage, well, some of these fibers are long and some of them are short, and this is why we owe you apologies for middle school when you would have your voice that would squeak because some of these were lengthening and sometimes they weren't quite so long. Now, these tissues are very sensitive to toxic substances, especially cigarette smoke, and they get an inflammatory process as the result. And the net result of chronic inflammation is that you're going to get some collagen deposition and scarring, and this can lead to these little nodules on the vocal cords. Now, perhaps you've heard of some of your favorite musicians, singers having had to have quit their tour because they had to have surgery or they had to have vocal rest because of these nodules on their vocal cords. So that probably means one, if not both of these two things. One is they're abusing their vocal cords. When you're doing all these concerts for multiple hours in the evenings, you really need to do vocal rest during the day because these vocal, in the first place, especially if you're a rock artist, you're abusing your freaking vocal. And secondly, a lot of these musicians are secret smokers, and smoking is toxic to this tissue. Now, if you are a chain smoker, what's going to happen is you're going to have chronic inflammation with no chance for a full recovery, and this actually can permanently lower your pitch, as well as all the growling of being a rock singer, as well as pitch normally does fall as you age between childhood and your 20s and between your 20s and your 50s. So yes, you're not going to be able to hit those high notes when you're older. Inferior to the larynx, then we are moving into the trachea, which is a tube made of C-shaped rings. Remember, we're back to hyaline cartilage now. And the trachea sits anterior to the esophagus. As you grow, these C-shaped rings will enlarge with size. And the whole point of these rings is to keep the trachea open so it doesn't collapse down at rest. So here's my question to you that you should probably ponder for a while. Knowing that the cartilage is necessary to keep the trachea open when you're unconscious, and knowing that the cartilage grows appropriately as you grow in size, why is it C-shaped and not an entire circle? Because it would seem like a circle would be better fitted for making sure that it stays open for breathing? All right, stop and ponder that. And you thought I was giving you the answer, and you're wrong. So here we are back to this epithelium in the trachea. So at the bottom, you have a beautiful up-close photomicrograph of it, and then above it, you have the cartoon drawing, which I have put in the same direction it would appear in the trachea. So you gotta look a little bit harder if you want to use the cartoon drawing and not the photomicrograph. Once we get to the distal end of the trachea, there is a piece of cartilage which sticks up in the middle, which is an important landmark internally. So we don't see it on our models, but we know where it is located. And this piece of cartilage is called the carina, okay? Yes, I know if it was a girl's name, you'd say it differently, but this is how it's pronounced in anatomy, the carina. And what this marks is the end of the trachea, because from this point on, we have two openings traveling inferiorly, one going towards the right lung and one going towards the left lung. So now we have entered the bronchial tree. We are still just conducting air, okay? Just because we've started this pathway in the bronchial tree doesn't mean we're doing any gas exchange. So the bronchial tree is highly branched. In fact, it has 19 different branches, each of which has a name. And I know you're going, please don't make us learn all 19. And you're not going to have to. You're going to learn the first 3. You're going to learn 1 for the middle. Then you're going to learn the last 3. So you're going to learn 7 out of 19, not even half of them. And so once the trachea has branched, our first 3 branches are bronchi. So on the right side, the right primary bronchus is wider and goes in a straighter downward direction. Okay. Whereas on the left side, the left primary bronchus has to go over the top part of the heart. So it's a little bit narrower and it takes more of a left-hand turn. Now your primary bronchi are also known as your main stem bronchi, so you can use either term. As soon as you have a branch that comes off of this, then like look over here on the left, you can see that right primary bronchi is branching. Your next division is your secondary bronchus. It typically goes to an entire lobe of a lung, and then when it branches, you get your tertiary bronchus, which is going to a segment. So yes, all these lobes and these segments and subsegments, everything has names. You're only going to learn the names of the lobes. The thing is, as these bronchi branch, they get narrower and narrower and narrower, and they lose their cartilage. In fact, none of them has sheath-shaped rings. They just have plates of cartilage. So they are losing their cartilage as they go distally, which means they're losing their ability to stay open. And what they are picking up in their walls is smooth muscle. And you're like, oh, that's okay. Smooth muscle will hold it open. And I'd go, wait a second. What's the function of muscle? It's to contract. And when that smooth muscle contracts, it gets shorter. And do you think that shorter length is widening an airway? No, it's making it narrower. So if you get some particulate matter because you're near one of our forest fires or it's a Santa Ana and there's all those pollens in the air, do you really think that bronchial smooth muscle is going to open your airways? It's going to do the opposite. So here's what your bronchial tree looks like if you dissolve out all the lungs. So you can see if you turn your head sideways, it does kind of look like a tree trunk with all of its branches getting smaller and smaller. So once you're past the primary, secondary, and tertiary bronchus, from then you are into bronchial territory, okay? And eventually the bronchi lose all their cartilage. Okay, so just bronchus, 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 bronchus. Sorry, just bronchus, bronchus, bronchus for primary, secondary, tertiary. Then bronchial, 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 bronchial. Say that about a dozen times. And then we're to our last 3 structures. And for this, let's start at the end and work our way back. So the very last structure is like the grapes on a little thing of grapes. And in fact, buy yourself some grapes and practice this. And each one of those grapes represents an alveolus, and they're usually in a cluster, although rarely you can have one that sits off a stalk just like you can in a bunch of grapes. So the airway that leads to the bunch of grapes is known as a respiratory bronchiole. And then the one right before the respiratory bronchiole is called the terminal bronchiole. So after you say bronchiole a bunch of times, then you're going to say terminal bronchiole, respiratory bronchiole, and alveolus. So now you're kind of going, Dr. Powell, do you not even know what that word terminal means? I think you've got these backwards because terminal means the end. So terminal bronchiole should be the last one before the alveolus. And I would go, yeah, terminal does mean the end, but what terminal bronchiole is indicating is the end of the conducting portion of the airway. It's the last part where there's no gas exchange from the time it entered your nasal cavity all the way down to the terminal bronchiole. No gas exchange whatsoever was occurring. After the terminal bronchiole, once we're in the respiratory bronchiole, that's why it's called the respiratory bronchiole, because we're going to do some gas exchange here. So this is where the epithelium changes, and then that same new epithelium is going to be found in the alveolus. So now we are done with our airflow pathway. Hopefully you can write it out, and I will see you again shortly. Thank you.